my name is Lisa Sabir. I'm an emergency medicine doctor currently working in Sheffield. At the time of starting this project, I was working in the Sheffield Children's Hospital. And essentially my project was looking at using forecasting methods to look at emergency department lengths of stay in order to workforce plan. So the issue that we were looking at was basically to predict the length of stay or the arrivals in the emergency department at different times of day, days of the week and months of the year. The reason why this project came about is because crowding in the emergency department is a major health issue, not least because of the adverse patient outcomes. So there's been some studies which I'll talk about that demonstrate an increased mortality, delays to giving or starting treatments such as antibiotics and sepsis, patient experience of the whole journey. If you imagine anybody that you care about or relatives that are waiting a long time in A&E, isn't particularly pleasant. Adverse effects on staff, which can lead to burnout, so feeling that you can't provide the best care that you'd want to be able to provide. And then it also has a knock-on effect on ambulance waits and handover delays, and that prevents them going on to attend other emergencies. So as a bit more background, sort of this time last year, you may have seen quite prominent in the news, and this is a recent paper that was published in the EMJ, and there's a QR code link there for anybody interested. So this is a big retrospective observational study that looked over a 2-year period at type 1 EDs. And they were looking at the primary outcome they were looking at was all-cause mortality within 30 days of admission. And quite strikingly, the conclusions was they found for patients who were delayed in excess of 5 hours from arrival to admission, there was a linear increase with respect to mortality. And probably that last line there, for every 82 patients admitted whose time to inpatient bed transfer was delayed beyond 6 to 8 hours from time of arrival to the ED is 1 extra death, which for me is quite striking results. So moving on from the Royal College of Emergency Medicine, who are sort of the overseers of the emergency team, they've got a winter flow project that they've been doing for a few years, and essentially the left graph here is looking at the 4-hour standard, which we've heard a fair amount of it about today. And what you can see is actually 2021 to 22 were significantly lower than the previous years. The target's 95%, but actually we're not really hitting that at all, even in previous years. The right-hand graph is looking at 12-hour stays as a percentage of all attendances, and again what you can see is longer wait times compared to previous years last year, and that's likely to continue into the following year. This obviously has financial penalties for trusts associated with delays to admissions. So lots of things affect attendances to the emergency department, so rising attendances, pressures on community services, so not being able to access services in the community, mean that patients turn up to the emergency department. Hospital bed occupancy, so it's probably a big one. Patients are waiting sort of social care packages. That means that they're occupying a bed in the hospital, which means that you can't get patients out of the emergency department into the hospital, and that prevents your flow. Different hospitals have different departmental capacities, but as you can imagine, there's a limit on the number of patients you can see based on your capacity in the department, and then also staffing. So quite a lot of these factors are sort of feel like I wouldn't be able to have any influence on, but some things like staffing, I thought if you could figure out when patients are coming and when they're staying longest, could you workforce plan in order to try and minimise some of the effect of this crowding? So the two methods that I aimed to use was forecasting and machine learning. So initially I wanted to produce sort of time series forecasts to be able to explore the trends and obviously the different areas of sort of resourcing in order to workforce plan. In order to do that, I've used a historical data set, and then the plan was to try and produce a tool that different trusts could use, and I used something called Streamlit, which I'll show you, which is an open source app that uses the Python language, and it helps you to create a shareable web app using your data scripts. And then machine learning using routine data I chose from January 2021 to 22, mostly to sort of minimise the impact that COVID would have had, and I'll show you the graphs for that shortly. So had some issues obtaining the data from the information governance team for Sheffield. So initially, all of the stuff I'm presenting today is actually the Somerset Trust, which is my mentor, Andy Main's trust. But hopefully we'll move on and get my data into there. So I'd recommend starting information governance forms early for the HLMO5 team. So essentially you produce a graph to the forecasting. So this is the number of patients presenting to the ED department. And what you can see here is this is the data that we actually had. This is the cutoff, and then it's just a 30-day sort of forecast here. And sort of trends wise, it's a bit of a dip here, which is COVID, and then a slowly increasing trend. And then just moving on, this graph here is the number of patients presenting. The top one is walk-ins, and the bottom one is ambulance patients. And again, probably it's by days of the week. Interestingly, sort of probably as you'd expect, Saturday, Sunday have got sort of increased patients coming in, whereas during the weekdays there's sort of slightly less, probably because there's more community services available and different methods that patients can access care. And then the next graph shows the same length of stay for patients who walk in and length of stay for patients coming by ambulance. Again, you can see the effect of COVID, so that's that dip there. You probably a small amount of an effect there with the ambulance stays, but not quite as prominent as demonstrated by the walk-ins. Probably interestingly, the thing to say about ambulance patients is this increase and sort of quite significantly higher length of stay compared to the walk-ins is probably because generally if you call an ambulance you tend to be sicker, you tend to need to be admitted, and then you need to wait for that ward bed. So I think that's probably the reason for that there. Moving on to sort of looking at that by days of the week, I think the most interesting part of this graph is that Mondays generally the length of stay tends to be higher, and the highest, and sort of my gut instinct of having worked in hospitals is probably because we're not discharging patients over the weekend, and maybe that causes a sort of knock-on effect to your Monday length of stay, and as you get further on in the week that drops down. So like I said, I'm planning to, I've got hold of the Sheffield Children's data now, so I'm planning to input that into the forecasting model that's created, and then work out its accuracy, and then add on things like holidays, because we tend, certainly in the Sheffield Children's, we see less attendances in school holidays, and certainly other areas probably likely to see more sort of holiday destinations. So I'll just quickly show you the Streamlit app. So that's this here. So it's got a template that you can download in order to then upload it in the appropriate format. So that's so different trusts can put in their data. So you just, as a bit of a demonstration, upload the file that you then put on, and then it will run and show the table. So this is just what I've been showing you there. So it's got the date, the number of walk-ins, the number of ambulances, and then their respective length of stays. And then you choose what you want to forecast based on what you've put in. So if we do self-referrals, you can then change the number of days. So it'll leave it to 30. And then it will show you the graph that I've already showed you before. And then again, you can change certain things about that and have a play with it and be able to sort of see your seasonality and trends. So that's that. I'll just come out of there. And then the next thing I wanted to do was look at machine learning. Unfortunately, I've not had enough time. It's been me on the project. I'm in the process of doing this, and it's not quite finished, so I haven't presented it here. But I'm happy to talk in the breakout room shortly about anybody that's interested. In terms of its impact, I'm hoping that actually if we can minimise the risk of patient harm, improve quality of care that we can give. I think organisationally understanding sort of patterns in length of stay and attempting to address ways to improve these is really important. I think the forecasting plus the machine learning will hopefully have quite an impactful way of demonstrating how we can try and improve this. There's obviously financial incentives, and the knock-on effects to the ambulance services hopefully will try and quicken their capacity to go to other emergencies. So yeah, I'd like to say a massive thanks to the HSMA team. Having not come from a data science background, it's been a very steep learning curve, but very enjoyable. I didn't think I'd be able to produce something like this. And Dan in particular for sorting out all of the organisational factors. And a massive thank you to Andy Main, who's been very, very helpful and very patient with my "I can't get this code to work, what's happening" comments. So yeah, thank you very much.